Well, and most importantly, got the pleasure of learning from this guy, from Lonnie Peterson, from Stuart Harris, and a lot of the other people you've seen talk. I recognize the challenge of being the last person to speak to you all before dinner, so I make two promises to you. The first is that I won't talk about my research niche. In part, that's in self-defense because Faisal's a lot smarter than I am, but secondly, it's also because I recognize we're at our glycemic nadir, and I'm going to try to keep you all from that. So only 2 of my slides have text on it. The rest are going to be photos. And I have the challenging task of distilling all of a subspecialty of emergency medicine into 15 minutes. So we'll see how we're going to do. When I came here, emergency medicine by background, I did train in wilderness medicine with Stuart Harris and then in space medicine with Eric and Stuart afterwards. It was a condition in my contract that I got to play with new dogs in every remote location I went. And these are my favorite dogs. This is a group of dogs that race the Junior Iditarod up in Alaska. So I try to find them anywhere I go, and you might see them pop up in a few more slides. What I'm going to talk about today is the connection between these 2 photos, which at first glance probably look quite disparate. On the left is a photo I took of Karma Sherpa on the summit of Island Peak. Island Peak sits at 6,000 meters elevation. You can actually see the head wall of Lhotse behind it. If you were to duck over that mountain behind, Mount Everest is sitting right there. And there's a really interesting tradition. If you have the privilege of going up to Nepal and climbing some of the peaks there, you'll see that there are prayer flags at the top of each. The first climbing team to reach the summit on a given morning has the responsibility of digging those flags out of the rime, out of the ice that's crusted on top of the mountain, so that they can serve as a guiding color for the groups that come afterwards, as an inspiration for the teams that come up behind. On the right side, we have 2 SpaceXers, really tremendous friends and outstanding space medicine practitioners for the Axiom 3 crew training out near Pennsylvania at the NASTAR centrifuge. So an air-conditioned facility in Pennsylvania may seem a far cry from the top of a Himalayan peak, but I've got about 14 minutes now to bring those 2 together for you. Todd Erickson set me up pretty well yesterday when he talked about Everest as an analog for spaceflight by virtue of the number of people who've gone. But if we think about the difficulty of human expeditionary travel on a meter stick of when it happened, high-altitude travel and spaceflight are extraordinarily closely co-located. Right? If you think about the North Pole, which Peary reaches in 1909, you think about the South Pole, which Amundsen reaches in 1911, those are half a century before someone makes it to the summit of Everest, and then just 8 years later, we make it to space. So clearly, there's some physiologic challenges, some logistical challenges that are extraordinarily similar between these 2. All right, this is one of the 2 text slides. We're going to limit this to just 4 brief topics because we're so limited on time. The first, we're going to talk about supplies, how you pack for a trip, both for the wilderness and for space. Then we're talking about remote diagnostics, then imaging, and lastly, and most importantly of all, treatment. So the first thing I'm going to talk to you about is the backpack problem. Those of you who work in spaceflight know this very well. It's the mass, power, and volume problem that we all face when we pack for spaceflight. But it's an old problem, and it's one we've had for a long time in wilderness medicine. If you're leaving on an expedition to treat a group of people in a remote place, you can't bring the whole hospital with you. So what do you bring? And that answer is different based on where you go. This is a trip that I took with both Dr. Lonnie Peterson and Dr. Casper Peterson back in July of this year to the North Pole to support 130 runners whose goal was to run a marathon on an ice sheet at 90 degrees north latitude. Now, our power, mass, and volume restrictions for this are actually extraordinarily minimal. We're taking a liquid natural gas-powered icebreaker that can host just about as much power as we want. We have enough LNG for 2 round trips to and from the North Pole. We have open cabins and open cargo space. We can bring just about all we want. We're really only limited in the sophistication of some of the technology we can bring and by virtue of how remote we are. So in this case, despite how austere it is, we're fairly little constrained in what we can bring. In contrast, this is another race medicine event we did in January of this year. This was a different group of runners who endeavored to run a marathon on each of the 7 continents in 7 days. They ended up doing it in 5.5 days, setting the world record for the fastest woman to run a marathon on each of the 7 continents. Here, we're much more medically constrained. Our med kit has to fit in the overhead bins of the airplane on which these runners are sleeping. And if someone's kidneys decide to stop working in the middle of an 8-hour transatlantic flight, we aren't going into the cargo hold to get what we need to get them back up and running the next day. All right, and lastly, and probably most challenging of all, is this. Anything that comes with us on a 3-month expedition into the Himalayas has to be carried up by yak or by human. And then the kit that comes with you on mountain is carried by you. And so what you choose to take with you is even more constrained than that larger kit that came up with you into the backcountry. And this is exactly the problem we think about for those of us who think about medical systems for spaceflight. And what you bring on a 5-day orbital mission is very different than what you bring on a 10-day mission, or what you bring to the moon, or what you bring to Mars. It's not a problem we confront most other places in medicine, but it's a problem we think about all the time in wilderness medicine. All right, we can't always go to where the patients are, certainly true in spaceflight for those of you who have sat on console. This is a remote location we work at in northern Alaska, just north of the Arctic Circle. Kotzebue is a town of 3,000 people with 10 outlying native villages, each of about 300 individuals. This dead end sign actually kicks off right into the Arctic Ocean, so make sure you don't drive past it. We've had a couple do that, and it makes for a rough night in the ER. This is what the town looks like when it's sunny, which is certainly not all the time, especially if you go in winter. And this is the conveyance of most people. It's all ATVs and snow machines, which for those of you who work in the trauma world, leads also to some fun in the emergency department. But most of all, we can't staff emergency medicine trained providers or even medically trained providers in most of these villages of 300 people. This is a very common sight if you're working in the emergency department. It's a call in for a telemedicine consult from one of the community health aid providers. And I will say, just as a quick caveat, any patients shown have all given their consent to be shown here. This is a family coming in for chest pain. The patient who's having the chest pain is actually the woman sitting in the back, but by virtue of the local traditions, the older man who is telling the story is not the patient, but he is speaking on behalf of the family member who's there. And the medical provider in this setting is the woman standing off to the right side of the screen. Now, she's what we call in Alaska a community health aid provider. She's had about 4 weeks of medical training. She will do chest compressions on cardiac arrest. She will do resuscitations of infants who die in the community, and she will help us diagnose chest pain or other maladies that show up in the villages. And so we don't do this a lot in the contiguous 48 states, but it is something we do in remote Alaska. And when you think about talking to an astronaut who may not be medical, who's had 4 weeks of training somewhere back, right, in their previous training, and you've got to walk them through something tough, there are very few analogs as close as this. And don't take it from me, take it from Johnny Kim. I know we couldn't have him speak today. Why is this a photo of a computer screen? Well, this is actually a photo I took the second day after we left the North Pole. This was taken at about 88 degrees north latitude. Johnny Kim was kind enough to come and speak to the residency here, and we got to speak to him afterwards. And thanks to Starlink, we had a direct conversation with him from 88 degrees north latitude while he was orbiting the Earth on the International Space Station. And when Johnny spoke to us, I asked him directly. I said, if you could have one medical capability with you on the ISS, what would you bring? And he said, I only trained with you all for 1 year at MGH, but what I miss the most is being able to jump on a video like we have now and talk to an expert in their field about what's happening here on station. That's something that's becoming possible, right? You heard from Todd Erickson yesterday about laser-based technologies being able to communicate in video in real time with low Earth orbit, but it won't be possible on the moon and it won't be possible on Mars. So at times we still have to go to those locations and develop the medical technologies to bring the hospital to them. Lonnie showed this great photo yesterday, the first X-ray ever done in spaceflight. Performing an X-ray in space is tough. Performing an X-ray at altitude is also very challenging. I want you all to take a little exercise with me. I want you to think about the image that the words Margarita Hut brings up in your mind. This is the Margarita Hut. Probably not what you were expecting. This is a small research station that sits nested in the Alps, and it's a tremendous place where we can go to study high-altitude physiology. One of the first X-rays of high-altitude pulmonary edema, a collection of fluid on the lungs, was done by someone who carted an X-ray all the way up to this hut and took X-rays of people with difficulty breathing coming into the Margarita Hut. Marissa talked yesterday about the challenges of qual for the X-ray machine that went up in Dragon, and it was challenging. I can say that certainly. This is its own different kind of challenge. X-ray, CT scan, MRI, they aren't primarily what we use when we think about diagnosis in the wilderness, nor in spaceflight. It's an X-ray of HAPE. This is the first ultrasound that was ever performed in 1964 in Glasgow, the size of a room. Anymore, ultrasounds often look like this. Our group back in the early 2000s was one of the first to take ultrasound up into the Himalayas to look at high-altitude pulmonary edema and create the diagnostic criteria for high-altitude pulmonary edema on ultrasound. This is Dr. Harris taking an ultrasound on the summit of Denali, measuring optic nerve sheath diameter. So swelling happens also in the brain, much like we think about for astronauts, and ultrasound is one of the promising ways we have to try to diagnose that. No longer, though, do we rely entirely on optic nerve sheath diameter. With Dr. Peterson's lab, we also do ultrasound in parabolic flight to look at other surrogate measures for fluid shift in microgravity. But we still take ultrasound up to altitude for research studies because the number of people who fly to space, as you heard yesterday, is extraordinarily small for now. But sample sizes that we can study in the Himalayas are much higher. In 2023, we did a study of over 400 individuals looking for asymptomatic fluid collection in the lungs, all with a handheld ultrasound. So you see I'm looking at my cell phone there. That's the screen. In my other hand is a small portable ultrasound device about twice the size of this clicker that I'm holding right now. And that's how we do research. All right, I promised I wouldn't jump too much into my niche, so I'll jump over the beeline presentation here, and I'll jump through pulmonary artery pressures as measured by ultrasound, and straight into this, Dr. Strickland's excellent work on CPAP at altitude. So it's not just good enough to go to these challenging places and make the diagnosis, you've got to develop new ways to treat people there. CPAP is very common here terrestrially, but the problem at getting this to altitude is again a mass, power, and a volume problem. If you were to come to our Ferry Shake Clinic, this is our power setup. You'll see tucked away behind that bed that has all of our equipment for internet are a series of lead-acid batteries connected to a small set of solar panels on the roof. If we have 2 days of sunlight, we can get about 1.5 days of total power for this to drive oxygen concentrators for up to 4 patients. So if we have 6 patients come into our clinic, all suffering from pulmonary edema, we can treat them for roughly 20 hours. So we are extraordinarily power constrained when we think about this environment. And if you think about the modern CPAPs, those of you who are clinical, who work with ventilators in the hospital, they're not mass efficient, they're not volume efficient, and they're certainly not power efficient. And so how do we develop something that we can take to these remote locations and treat these people better? And the answer is we rely on our friends on this side of the Charles. So this is a device that was created by a group of device design students here at MIT looking to make a rugged, portable, positive pressure airway device. In this box, we have not an LCD display because they don't do well in low temperature. This is actually an e-ink display that can go down to temperatures of -30 and still function. We have 2 stacked pumps that have been tweaked fairly significantly so that they can work up to the summit of Everest in terms of altitude, also not something you find in our conventional CPAP machines. And then it was also a challenge for the students to make this what we called yakable. In other words, my challenge to them was if this fell off a yak on its way up the side of Everest, would you be able to pick it up, dust it off, pop it back on a patient, and make it work? And this does. What I'm most proud of them for, however, is this. For those of you who have seen Pulp Fiction, you know there's a MacGuffin in that movie. Travolta and Samuel L. Jackson take around a briefcase in the movie, and it's the MacGuffin that drives most of the plot. And when they open it, there's a light that shines, and Tarantino never shows us what's inside that briefcase. Near the end of our project, about the second to last week, one of our students ran up to me and said, Dr. Luke, which is what they all call me. I tell them not to call me doctor, but old habits die hard, I suppose. We took the light bar that we installed on the BiPAP. And why do we have a light bar? I'll take a quick tangent. It's because when you're in a blizzard on the side of a mountain, you don't want to try to read that e-ink display with your headlamp way up close. And so this light bar has taken all of the problems that can go on with our BiPAP, it's streamlined them into the 5 most common ones, and then it flashes an error code to us in one of 3 different lights. So you only have to remember 2 error codes and 3 different colors, and you know most of the error states of the machine. So you can troubleshoot it without even looking at the screen on the device. But they ran up to me, they said, Dr. Luke, we took the light pattern for the middle lighting, this yellow lighting that we have, the warning state, not the error state, and we made it the exact same RGB as the light from the briefcase in Pulp Fiction. I've never been prouder of one of my students. Like Dr. Harris said earlier, right? It's not just about solving these fun problems, it's about solving the problems and having fun while you're doing it. The student on the left here, his name was Rafi. He will come back here in our story. This is the vacuum pot that we use to test some of our smaller components. Take them up to the altitude of Everest, Camp 2, Camp 3, and see how they function. Before we go to that, I have one other slide that I don't think made it in here. I have a story from about 4 months after we worked on this device. You all may remember from Todd Erickson's talk the suspended operations that Commander Isaacson did as he was prepping for Polaris Dawn. A big part of what we did when we were preparing for that mission was the thermal testing, and that thermal testing had to be overseen by a physician on site. I was there at the time, and I was going to oversee Jared's thermal testing. And as I was walking on the way to the crew training facility, I heard from behind me down the hall someone shouting. And they're shouting, Dr. Luke, Dr. Luke, which is not something that ever happens at SpaceX, nor should it. And I thought, who the heck is this? And it was Rafi. It was the student from MIT who had worked on the BiPAP project. And I said, what the heck are you doing here? And he said, I was so excited by all the space medicine you told me about while we were working on that BiPAP project that I decided to apply to SpaceX. And I got in and I got the job, and now I'm working on the life support systems. So what is the power of this ecosystem in a nutshell to me? It's that we send a physician out into the wild to create new treatment paradigms, to see what the problem is, to come home and bring them across the river to our colleagues here to help us build the solutions, and then use those solutions to inspire the people who are going to go after us and create the solutions of tomorrow. Right? We don't climb the mountain just to say that we were there. We climb it to pull out the flags for those who come after. Thank you.